Good evening, and thank you for joining us tonight. My name is Corinne, and I will be your moderator. We are excited to welcome Dr. Edward Lowe as our speaker tonight. He will be providing insights on indirect anterior restorations and how to overcome aesthetic challenges. If during the webinar you have questions, please drop them into the Q&A section of your control panel, and we will answer them live at the end. And lastly, we are offering CE credit for attending tonight's webinar. If you are interested in receiving CE for tonight's webinar, please click on the CE available widget on your console and complete the survey. The CE available icon is located on the upper left side of your screen, as well as the bottom of your control panel. If you have trouble locating the widget and link, please email webinars@henryschein.com and we will send it over to you. All right, let's get the show on the road. Dr. Lowe, welcome, and thank you for being with us tonight. I'll pass it on over to you.
All right, thank you for having me, and welcome everyone, East Coast and West Coast. I'm in Vancouver, of course, and our time is 5 p.m., so for you on the East Coast, it's probably 8. I want to thank Henry Schein for the opportunity to present this, and I have received financial contribution from Henry Schein for this webinar. Now, all the images you've seen are my own, and aside from global adjustments, nothing has been changed with the images that you're going to be seeing tonight. A bit about me: I practice in Vancouver, BC. I'm a 1986 university graduate, and I live in Vancouver. And I spend 4 days a week here in my private office, so I practice full-time. As well as do other things like, of course, running these seminars. I have my study club, I lecture. So I enjoy speaking and sharing things that I've learned with people like yourselves listening in tonight. And if there's any insight or anything, tips I can offer you, I'm really happy to share them. I evaluate products. I take a lot of CE as well on my own. Other things, I'm the editor-in-chief of the Journal of Cosmetic Dentistry since 2010, so if you're interested in writing on those topics, please let me know. And I do a lot with the American Academy of Cosmetic Dentistry, so that's my passion. Today's going to be a great program. You know, I know it's about aesthetic challenges. In putting this together, I had a lot of different ways I could present it, but I think you're going to enjoy following along. I'm going to go over how to diagnose and treatment plan anterior cases, not specifically one restoration, but how do you put a case together? And I'm also going to talk a little bit about the prep and get you to the point of provisionals. We don't have time to talk about cementation. That might be another day, and placement, but certainly we'll get you to the provisionals and how I do it. Talk a little bit about the materials I like to use for cases, and what I'm really excited about is getting to some of the case studies. So I'm going to show a lot of different cases, how we handled different things in different situations. So let's start right away. The road to comprehensive functional aesthetics. I mean, obviously we want to do, one crown may be difficult too if you're trying to match something. So whether it's 1 tooth or 32 teeth, everything you do affects the entire masticatory system, the way someone chews, appears, and bites. So why do we do what we do? And I always say why is so much more important than what to do and how to do it. And the reason for that is, I can tell you what to do when a patient presents with something or how we're going to prep a certain tooth. But I think that understanding the why is really important. Why do you choose to do it this way over that? Or maybe pick this material? Or why treatment plan it this way? Certainly, these are things that I'm inquisitive. I always want to ask, but by understanding why, you can be way more comfortable with what to do and how to do it. Okay, so our goal for today is to understand why. Why are we prepping it this way? Why are we planning it this way? So let's say you want to restore every patient ideally. And I say to my patients, when they come in, I said, I'm going to make you a 10 out of 10. If I could, I'd make you 11 out of 10. But if it's your choice if you want to be a 9.5, a 9, 8.5, or 8. You're starting, let's say, at a 5 or a 6. Okay, so if you could restore every patient ideally, what would you do? He walks into your office and wants a new bridge and veneers. He's wondering how he can eat and smile again. And these are patients that walk in, and quite often they're pretty daunting. She wants to whiten and close some gaps. he wants veneers. So he walks in, he's going to get married soon in time for his sister's wedding. And he says, I want veneers. And I think he's even prepped his own teeth because there's not a lot of tooth structure left. How are you going to manage that? This gentleman wants a nicer smile. And with proper planning, yeah, we can do that. We can give you your smile back and make you a little bit more youthful. She certainly wants to look younger. And, along with the teeth and doing everything else, we can do that too. I mean, she's in her early 70s. So we can make you look good as well. So how do you manage these cases? So I think that planning your moves and putting everything together using case analysis makes your life easier, especially when you're doing indirect anterior restorations and cases where you can see. In the posterior, you may not see something, but in the anterior, you're always seeing your work. Generally, what could be is this, and when I talk to people, I want a perfect fit at the margins. I want great aesthetics, perfect contacts. They bite together and everything fits. Isn't that a dream case, whether it's one tooth or an entire smile? But what ends up happening is the case does not always see, or maybe it's canted. Maybe the patient's bite is high or open, and it's not the aesthetics you dreamed it to be, and it's not what you or the patient wanted. And so the patient's unhappy. And the consequences, they want their money back. They start seeing another dentist in your area. They lose confidence in you. And, the consequences, you lose time. If you have to redo the case, often you lose your profit margin on it. You lose credibility. And sometimes you lose your cool because you're just simply angry or frustrated, right? So, you blame the lab, the impression materials, sometimes your team. And worst of all, sometimes you blame the patient. Oh, they've got a small mouth, or, they're moving around, they salivate a lot, they got a gag reflex. But really, whose fault is it? You got to look long and hard in the mirror. So in order to avoid this, by embracing a methodical system for collection of data, the process of forming a treatment plan becomes really straightforward and predictable for you, the clinician. Because then you have a roadmap of what you're going to do, and you're not going to see things that come up unexpectedly down the road. Treatment plan is exploring possible solutions. So the things I really think for a predictable treatment plan that you have is vital patient data, the medical dental history, the proper number of radiographs and photos, etc. You need your periodontal data, which is your gums, your teeth, your jaw joints and chewing muscles, and your dental facial data. I'm a Coyce disciple, so I follow a lot of the way John talks about things. So periodontal, biomechanical, functional, dental facial. So it gives us a system to plan cases, and it gives us a strategy to reduce stress and prevent failure on comprehensive cases. For example, a guy like this, Brad, comes in and says, I really want veneers, and he smiles, and you're looking at the case, and he says, I'm in a hurry, and he bites like this. This is his bite. So patients don't come in saying, I need to increase my vertical dimension and reestablish my anterior guidance. They simply come in and say, I want a really nice smile. I want to look good, right? And I want them, whiter and brighter than what they are. So often a patient comes into your office, and always says aesthetics drives the case. I mean, they'll come into the office because they say, I want to look better. But in the end, it's really function finishes the case. So if the person has a beautiful smile, but they can't eat or chew, they'll be back real soon to talk to you about it. All right. Aesthetic dentistry is not just about pretty teeth or whitening or bonding or porcelain veneers. Aesthetic dentistry, or making anterior teeth look good, is the end result of excellence in understanding the perio, endodontics, restorative dentistry, ortho, good clinical decision making. It's also a result of excellence in orthognathic surgery, prosthetics, occlusion. You have to have a great lab. You have to understand implantology these days and how that works in with a case. Because, as a GP, I'm a general practitioner. I mean, I'm like a general contractor. I have to know a little bit about what all my specialists do, my subtrades do. And so by understanding what they do, I can work with them a little bit better and be able to be a better referrer and to help my patient understand what they're getting into when they go to see a specialist, and have them less stressed about going to visit someone. So here's a case. Kim comes in and says, I want to smile again. And you can see she's got some certain challenges in her smile. And if you look really carefully, she says, my teeth are sensitive. And if you look at her, I go, wow, they seem really worn down. What happened here? Well, Kim is bulimic and suffers from anorexia. And, her bone levels and her gum tissues are in great shape. But she wants to look like her high school picture. And when I look at Kim here, she looks quite different than her other pictures. So acrylic provisionals help. I mean, it certainly gives us a guide to what it takes in the anterior to return her to looking more normal, because simply she had worn her teeth away and is over closing. It gives us an idea of returning her to more youthful and appearance and function. So this is both a restorative case, and this is it finished that is both aesthetic and functional. So they're both equally important, but it all starts with diagnosis. Dr. Morton Amsterdam has said that there can be different ways of treating a disease, but there's only one correct diagnosis. And a correct diagnosis with no treatment is better than treatment without a correct diagnosis. And I find that to be really true. You've got to take the time when your new patient exam or your consultation to spend with a patient. So data collection for me is, in my practice, is really important if you want to do anterior cases and work with anterior cases, especially complicated cases, because you need to collect all the data, dental history, chief complaint, patients' perceptions of their teeth, their values, function, and aesthetics. So how do they feel about their teeth? Begin to know a little bit about their personality as well. Some people like doing this. I like to have them fill a smile evaluation as part of the health history. I like to know whether they're happy with their teeth, do they like them or not, and what's their main concern. What's their problem list they're coming in to see me about, right? Study models, if you take impressions or pour up study models, but nowadays I find digital scans, a lot of people have a digital intraoral scanner like an iTero, and you can do a digital scan and have the models, a 3D model in your hands is very valuable as well. Photographs are equally as important. In my practice, I want to make sure I have a full set of photographs. You want these to be consistent and take whatever photos you think is important. If you don't know which ones to take, the American Academy of Cosmetic Dentistry series is a good one to start with. So it's a list of 12 images that give you a great start to evaluating smiles and cases. All right. So those 12 images are simply that: a headshot, a smile, a retracted smile with the teeth slightly apart, and upper or lower occlusals, and the anterior teeth up front. Now, for me, I want more information than that. So this is my series of 20 I like to take for every new patient that comes in. You may have your own different tastes and take your own different ones, but I find this is generally the one I start with, and I can add more to it if I like. All right. And for those who don't have a digital single lens reflex or SLR or a mirrorless camera, almost everyone I know has an iPhone. These iPhone cameras are pretty good these days. So a lot of the Invisalign cases are being taken with iPhone cameras, and there's a lot of things that you can attach to an iPhone camera to use for lighting, and they take amazing pictures. So, you can't say you don't have a camera in the office because somebody will own an iPhone. Radiographs are a must. So, full mouth series and panoramic films are a must. Current radiographs, I don't want them older than a year if I'm seeing someone for the first time, because I don't want, 4 bite wings from 5 years ago. That's no way to start a case. And if you can order other radiographic images if you need them as well. So in your clinical exam and findings, that's when the patient sits down. You've gathered a lot of records. I evaluate the soft tissues, the TMJ, the teeth, the smile and the appearance, kind of so that I can categorize that. And I run my exam in kind of in that order, so that I have four distinct categories I can evaluate. So when I collected the data, I'll spend some time, and I always do that, and I'll discuss the photos and the images and the scans with the patient. And I really just point out the highlights. It's not time for me to plan the case, because the patient often say, well, what are you planning to do? And, I usually say, well, I need some time to study your case if it's more complex, or sometimes I honestly say, I don't know what I'm doing yet. I'd like to take the time to lay everything out, and I'd like to bring you back and go over in the length of time it takes to do things, what we plan to do, fees, and all other questions. And sometimes a patient isn't ready to tell you what direction they're willing to move in. So it could vary that way as well. So I think that a second consult is really helpful. Accepting compromises, deciding when we can make compromises to please our patients, is the toughest challenge in dentistry that we do. Like popular compromises, including a patient who says, well, I'm going to take away your tools. I don't want perio, or I don't want to do orthodontics, or I don't want to get surgery done, or restorations without functional considerations. Doctor, I'd like to repair this because I can only afford to do this at this time. Or they come in just for one thing and they don't plan to do anything else. And so it makes it challenging where you have to compromise. So, with all the data I gather and all the information I have, I usually sit down, and with the management data, I create a treatment plan, a timeline for the patient, so there are no surprises. It's invaluable for the doctor and the patient, but also the lab and referring doctors and specialists too. So once you have that, you can share that treatment plan with them. I usually give that a letter. I write a letter with explaining everything to a patient, and I give that to them with all the fees and everything else, all the information that they need. And it provides a good record for myself too. Should the patient be away for a while and come back, I can always refer to the letter and the information to go over what we discussed. So the key takeaway here is that in case diagnosis and management determines the level of teeth and gingival prep and treatment sequencing in order for us to have a predictable aesthetic outcome. All right. Here, I put this together a while back. For porcelain veneers, I guess it applies to all anterior restorations as well. Anterior crowns, anterior veneers, three-quarter crowns, clinical decisions that make you go, So as you're planning cases, I think these are things I would think about. Is this case additive or subtractive? Are you going to prep the case? Is there going to be reduction or no reduction, prep or no prep? Are we adding porcelain or reshaping teeth for an ideal result? Because not all cases can be additive. You'd be surprised that there are many more that you think, because half the aesthetic cases, the veneer cases that I do, are no prep or prepless. Another one is ortho or no ortho. Is the patient willing to do orthodontics? Are they adamant about it? Do they know the risks? Are they willing to do Invisalign when I talk about ortho nowadays? Because a lot of the correction that you can do with Invisalign doesn't make them 100%, but gets it close enough to where you can finish it with restorative. So a case like this one here can be finished much better, and we can do it prepless by moving teeth around and get her a better functional and aesthetic result. Here's another one with, is the patient willing to do ortho? Again, this is a patient that started out looking like this with a huge overjet. Very challenging if we were going to do it without ortho. She had the ortho and orthognathic surgery, as a matter of fact, to increase her vertical dimension, get rid of her overbite and overjet, and in her face, make it a little bit more balanced as well, so that we are able to do, once again, a prepless case with minimal preparation of teeth and get a really nice result for her. Oral surgery or no oral surgery, your class 2 and class 3s. What can you do dentally when the issue is skeletal? Does the patient know the compromise when you make a case like that? How many veneers are we going to do here? We look at this young lady, and she's definitely a class 2. If if you look at the lateral photos here, I mean, certainly you can see how her face, there's a discrepancy. She's kind of got a retrognathic mandible. And here, this is after, once again, she had surgery, and she looks like a whole different person. I mean, she's more well balanced. I think that she's much more attractive with everything put in place here. And so here with the class 2 corrected, it was easy. I mean, all she didn't like was the smaller lateral incisors, and we're able to put that together as well and give her a nice result. Here's a different case, a skeletal class 3. Now, would you prep this? Like, I wouldn't. I think it looks like a pretty challenging case, and you'd almost think, wow, you need surgery for this. So once again, she's looking like this, but the orthodontist got her into a much better position, and with more elastics to finish her off, and you change her face again. We didn't have to do surgery here, and I didn't do any restorative, but I was pretty amazed at the ability of my orthodontist partner to be able to do this for this young lady. Laser gingivectomy or osseous crown lengthening. I mean, is there enough biological width? I mean, does the patient have a high smile line? Will the overall outcome be effective if the gum heights are not ideal? Here's a case of osseous crown lengthening where the laterals are smaller, and by being able to balance someone out, I get a much nicer temp result and a much nicer finish just by doing a little osseous crown lengthening, because in this case, she didn't like her small laterals, and she thought her essentials were too big, which they weren't. It was just simply the proportions of the laterals. So we did some prepless veneers on her with some osseous crown lengthening. How many veneers did I do here? How many restorations here? And if you look at this case, once again, with the osseous crown lengthening, I was very lucky. I did a tiny bit of bonding on the edge of number 8, or 1-1 in Canada, and no restorations. We didn't do anything at all. These are her natural teeth. Change or leave occlusal scheme. Like, is the patient, do you trust that the patient's bite is where it is? Leave the patient in maximum intercuspation or CO. Should we deprogram this patient and find out where their jaw position really is? These are things that you have to think about as well. Do we treat the bruxing habit or deal with it after the veneer work? Do we equilibrate the case before or after the veneer work? These are questions that you have to ask. The age factor for me, if the person's under 35 years old or less than 35, I trend towards an orthognathic approach for restoring them. No prep or enamel contour veneers or restorations if possible. Generally fewer restorations because they have less wear. Now, if somebody is a little older, greater than 35, and I use that as a hasty generalization. I mean, it could be 40, but the above still applies. I want to be conservative, but I might consider a prosthodontic restorative approach if the person has a lot of old restorations or more wear in restorations. Let's say they're in their 50 and they had crowns in for 25 years, and their gum position's a little bit different, so they may want a different change with that too. Teeth heavily worn or restored, you can be more aggressive with heavily restored teeth, but use your clinical judgment. Teeth worn teeth could be added only as well, even though they have full coverage. So, if you're opening a bite, you don't need to necessarily do your depth grooves and prep a case as in the 2 examples you see here. And they might be a bit more of an additive case. Or virgin teeth. When I see virgin teeth, I get antsy because I don't really want to prep them. Can I move them into position so I can do very little? So the best dentistry always is no dentistry. So can I work that way to try and move them into a position that's satisfactory based on a lot of other small design factors? Dark or light colored teeth. Do you whiten the dark teeth? Do you have to subopaque and block out the dark teeth? Do you have to do anything else with it? What type of porcelain would you need to select? Do you prep more to block out the color? There are many different ways to kind of hide dark teeth. light colored teeth are much easier to work with, but unfortunately, we see a lot of teeth that have been endo-treated or tetracycline stains. Here's one: black triangles present or not. If yes, do you try and correct it with periodontal therapy? Is that possible? Can you do root coverage? What other ways can you close it? Would this change your strategy for how you prep the teeth? When I look at old composite, do I remove them? Let me step back a bit. Old composites, do I remove them or restore over them? So always try to replace old composites. Restorations may have decay under them, and you don't know that. Old composites do not bond well to porcelain as well as fresh composite. And, as much as possible, I want to restore large class 3 composites versus doing a slice prep as much as you can, or a wrap preparation, because I would try to preserve tooth structure as much as I can. Here's a popular one. Do I want to break contact points or not in the anterior case? When do you break contacts? What happens if you don't break contacts? I always try to preserve contacts if the case allows it, but in case of large black triangles or case of teeth that are rotated slightly that you want to correct prosthetically only, I think in order for the lab to be able to close the black triangle and hide the spaces, you need to break the contact so they can start the restoration and have the freedom to be not govern and have the position of the teeth conditional so that they can't move the teeth around or change the sizes of them. Feldspathic or pressable ceramic, that's a tough one. I mean, what material you're going to use. And I think for us, it's our duty as dentists to understand what materials we use. Feldspathic, what are the advantages of that? Lucite porcelain, what are the pluses and minuses of that? Lithium disilicate, zirconium, and all the others as well. So I hope those dozen or so ideas helps everyone think about a little bit about it isn't one thing. All those things help in your planning of anterior cases. Aesthetic dental materials, I say 2022, it changes all the time. I think there's so many different materials out there. Sometimes it's confusing what to pick. I think all materials are good. I think not all materials are there for the same situation. And so, some of the selection questions you might ask yourself, well, when am I selecting what material? You might say, well, is the margin supra equigingival or slightly below the free gingival margin? Is there something you need to hide? Is there going to be a color change? That's one of the things you ask when selecting a material. Is the gingival health adequate for adhesive protocol? Is it going to be easy to control any bleeding or moisture to allow you to bond it, or is it going to be a material that you have to cement conventionally? Is the abutment tooth colored or not? Is it a dark tooth or is it a light tooth? Do you have to mask something out? Is high translucency a priority? Is high translucency going to be challenging in certain materials that are a little bit stronger because it's a little bit more glassier? Is concealing the abutment color a concern? Because if it's too translucent, it might look gray, or you might not be able to hide the underlying abutment. Do you have adequate resistance and retention form? I mean, if the tooth is too short, I mean, it makes it tough to cement conventionally. Bonding alone might not be enough if you don't have enough tooth structure there. You may have to look at crown lengthening or extrusion of teeth, or different ways to give you more tooth structure to work with. And is the interocclusal distance adequate? Do you need to open the vertical in a case? Do you have to use PFMs with metal occlusion or zirconium to be able to fit it in or open the bite? What if the person is a heavy bruxer? Especially if the prep is short and tapered. I mean, what are you going to use in that case? Like in this particular case, I mean, this person's almost closed in on themselves. 100% overbite and a big overjet as well. and look at the over eruption of the posterior teeth. So there's some challenges there on what materials to use or how to even approach this case in general. So my anterior material choices for anterior teeth in a nutshell is I like feldspathic porcelain for prepless veneers, and when occlusion is not an issue. You can't build them too high, and they're a pretty material, very glassy. I think it's the prettiest of the porcelains out there. They're very lifelike. They're as much like real tooth structure as I've seen on excellently made feldspathic veneers. Another material I think is a good material is Empress Aesthetic for veneers and minimal prep veneers when occlusion is a little bit heavier but not destructive. So it's not really heavy, but maybe there's a little bit more canine guidance that you may not want to risk a feldspathic veneer. But now it used to be readily available. Now it's only available in the millable block only. But I used Empress, and Empress has been around as a lucite porcelain, been around for quite a while. Another good material that seems to be in vogue and popular for a lot of users for a lot of situations is Emax or any lithium disilicate porcelain. When the occlusion is the primary concern, I still want an aesthetic result with veneers and crowns. The occasional anterior bridge can be done in Emax as well, but it's a lot stronger than the other two. So feldspathic is very weak, and prosthetic maybe 100 megapascals, and sheer in strength. Emax is closer to 500, and then of course you have zirconium, which is closer to 8 to 1,000 or more, depending on whether you layer it or not. It's for longer span anterior bridges and occasionally crowns on a very heavy bruxer. I'm not a big zirconia crown person because I like to bond my crowns in. I use, I think of all the materials in the posterior, I use Emax more than zirconium. And if I had to use a zirconium crown, I think it's where the person is destroying Emax, or they've got a very heavy occlusion. So I'm going to show some fun stuff. We're going to keep moving along fairly quickly here. And here's a myth. Partial veneers don't work. And in reality, sometimes less is better. Pascal Magny found that 65% of a tooth's integrity comes from the cingulum and approximately 27% from lingual marginal ridges. So whatever preparation you do on anterior teeth, I mean, the last thing I want to do is crown it if I don't have to. If I can preserve it, especially the cingulum, where the greatest strength of an anterior tooth is, I would do that. So, can I open the bite? Can I avoid prepping? That's why the main reason why I would try to preserve tooth structure. I think when you cut over prep anterior teeth and you're down to dentin, you're asking for risk from those teeth of just snapping off at the gum line, especially if they're thin. So here's a case I called car plus teeth equals trouble. It's a dentist who was in a car accident, and she chipped her anterior tooth. And I said, well, I'll offer to do a class 4 composite on her. And she says, well, I just want something more permanent. I'd like to put a piece of porcelain there because I don't want to have the color change or have to replace this down the road. So here's where we just minimally prepped the tooth, just got rid of the sharp edges. The Polarize is a cross-polarization filter. I think that it's something that you can get from either Polarize, but I know the camera supplier, Photomed, carries it too. It's a cross-polarization filter. And so you notice in the left picture, you take a picture, you see the glare, you really don't see the true colors. In shade selection, especially where on the right photo all the glare is removed and you can see the true color of the tooth. This was done refractory by my lab, and powder liquid porcelain and feldspathic, and you can see all the buildup and the steps to create this partial, this class 4 in porcelain. Its finished restoration is tiny. I think it's more like a third of a tooth, to be honest with you, but it was great. And it came back to my office. I have to tell you a story about it. It came back to my office, and I I took it out of the box, and it was so small we dropped it. And so here we are on our hands and knees trying to find the veneer. I never did find it. Found it. I never did find it. My lab phones back and says, "Where is it?" Nelson Rigo phones me, my ceramist, and says, How did it fit?" And I go, "I lost it." So it was pretty funny. So he made me another one, but there was a little bit too much hypocalcification on it. So after adjusting the hypocalcification, I think that here's the end result. We ended up with a pretty nice class 4 on tooth number 8 there. And here it is close up. So I think that was a pretty good result for what we ended up with as a partial veneer. Here's another case, no prep veneer case with bell-shaped teeth in the anterior. And so here's a challenge. She has pretty nice teeth. She's had ortho before, but she's worn out 8 and 9 and 24, 25 on the lower. Just the central incisors, as you can see, they're bell-shaped, so it'd be hard to do a no prep case because you'd leave it open at the gum line. And if you were to prep it, you would cut a lot of the natural tooth away because she's not missing that much. So that's what they look like there. And so here we are. We picked out the color. She did some tooth whitening to take her a shade or two brighter. And the clearance, incentric and protrusive before preps, not much room. After preps, and the ceramist likes it a little bit more. The lower we had to prep because she's biting on it. So incisally we prepped it. Alternatively, you could try and intrude those teeth and create some room too. But we did a little bit of the prep of the lower incisors. And the upper one, we did nothing except put a margin line in. And so the upper preps pre-op look like that. And the lower preps pre-op. And the lower preps look like that, okay, before cementation. So here's the lateral view of the preps. So just a light margin on the upper, so a finish line, so the lab knows where to finish it. On the lower, it's a minimally prepped veneer. Shade selection with a polarized to confirm, and these shots are just for the lab to be able to see. And so after that, I used direct tetric Evoceram composite to make provisional prototypes for the lab. Now, some people like to do composite veneers. Some people like doing indirect anterior veneers. I think composite veneers are a great way to learn about how to shape teeth, anatomy of teeth. You learn so much by being able to do a set of 6 anterior composite veneers. However, there's a huge learning curve. It takes time. It takes a lot of your time, investment, education to be really good at it. But I think every dentist should pursue that and try to be better at doing anterior bonding, because I think that's a staple. And if you get good at it, everything else is easy because you begin to understand shapes and teeth. So my choice, if I have to do a veneer, if I can do some bonding on it and make it simple or combine it, I think it opens up more avenues and more ways you can restore a case. So here's prototypes, and here's the ceramic work on the upper centrals by the lab, and here's the lower centrals by the lab. And so here's the case, trying them all in. You can see the shape. I'm going to have to recontour a little bit when they're cemented in. So after finishing down 8 and 9, that's what the case looks like close up. And that's what her smile looks like before and after. And you can see that by reshaping it, it looks like they fit on the anterior, and so that's the post-op portrait. So a nice conservative result for her. I'm going to go over really quickly the 10-unit classic minimal prep veneer case so that we can understand making provisionals and everything else. Here's a case of a girl in her early 30s that she doesn't like her composite bonding on her lateral incisors. Wants improvement in the general wear. So that's her pre-op retracted smile, occlusal, And so we're looking at shade selection here. I think she's looking at about an A1 or B1 in color, and she wants them to look the same. So I'm going to do a clinical mock-up here because I think that I can add to this and not have to add too much to it. So central incisor length, I want to get the central to lateral relationship right. I want to achieve canine guidance, posterior occlusion and protrusive, a good arch form, relation to the interpupillary line. I want it to be parallel to her, a line drawn between her pupils, and that the phonetics works for her. So here I've mocked up half the case. The advantage of a direct mock-up is total control by the dentist, and the accurate PVS for provisionals is accurate, and all tissue changes that you make are recorded. But as I mentioned before, it's time consuming, and there's a bit of a learning curve to be able to shape 6 teeth in composite like that very quickly. So now that I've got this done, I also use Bowley gauges that are useful to measure lengths and widths. So they're very helpful to keep track of how much length you want to add and relay that to the lab. Here's my final mock-up, and that's what she looks like. And then I take 2 impressions for provisionals using a full arch triple tray with clear bite registration and wash. And I'll peel the tray from the frame after removing it from the mouth because I'm going to make provisionals this way. Now, this is a direct way of doing it. I mean, you can also have the lab do a wax up and get you putty matrices to do it as well. So that's in the wax up technique. But here I'm doing it direct, so I have a little bit more control. Prep these teeth. I want incisal depth cuts with a coarse chamfer burr, 856016. And then I want facial depth cuts of 0.6 because they're going to be thinner Empress veneers, and thin cuts of 0.6, interproximal depth cuts, and you can use a fine finishing diamond to do this as well. And I just want to lay in there. So I'm putting all my depth cuts first. I'm scribing the margin equigingival, and a light chamfer is placed at the gingival. Now, I just simply connect the dots. So I join all my depth cuts in one sitting, so I don't do one tooth, move on to the next. I try to do everything at once. I get a better picture of what things are going to look like that way. I'm going to prep an interproximal elbow with the fine finishing chamfer diamond because I'm really trying not to break contact here because I don't need to, and it helps hide the margin as well. So I'm going to follow the gingival and proximal papilla contour to do that. And then I'm going to fine finish the facial. So it's a minimal prep case because she had bonding and her laterals were prepared before. So, maybe today, you can argue that maybe it could also be done prepless as well. So I remove the unsupported enamel or any undercuts with a fine mosquito burr. And the lingual margin is prepped with a fine football or round end taper diamond. So the incisor prep, it's a long bevel for the lingual margin on an incisor. And a long bevel is simply a bevel that's slightly tilted 60 degrees for the incisor. So it looks kind of like this. So you've got your incisal lingual long bevel is placed, and there's like a 45 to 60 degree angle from the incisal edge. The canine marginal placement is a lingual chamfer if the tooth is thick, or a lingual 60 degree bevel is if it's not really thick. So you can make your choice there because it's a thicker tooth. You can imagine that trying to place a chamfer on a really thin incisor, you're going to end up making the edge really too thin or continually shortening it. The case is going to be seated prepless or no prep. The final restoration must be seated really carefully. The lab may need to extend the veneer over the incisal edge just to be able to seat it. And I find it rarely do I need to prep a premolar. Most premolars can be done prepless. So here's a case where we didn't prep these premolars because simply we wanted to widen the buccal corridor so they didn't need to be prepped at all. So make sure to consult with your lab about that on these cases because I rarely prep a premolar if I'm doing facial veneers, all right? So here's a case. I'll take the case now in the preps and I polish with a 3M Softflex XT medium disc, making the preps nice and shiny. And then from there, I'm doing my shade selection here of the prep shade. And then your final preps, that's what they look like. And then I make sure I take the photos for the lab of the preps as well. I want them to see what's there and record it all, occlusal and close up. And then I desensitize and spot etch the teeth only if necessary. So I'll spot etch generally the center of the tooth because I want to be able to bond the teeth. And then I insert the pre-op impression filled with Luxitemp, or you could use Integrity or your favorite acrylic. I find that if Luxitemp polish is nice for me, and the Luxitemp Ultra seems to be a bit firmer, so I like using that. But there are many good products out there you can use as a provisional acrylic self-setting. So this is B1 in shade. So once I gently peel off the matrix, I mean, look at that. The adaptation of the gum tissue is pretty good. So they're shrink wrapped or locked in. There's no cement. I don't intend to take them off. And so using an ET9, like a fine carbide burr, 8-bladed, I'm just going to finally finish it around the edges and polish the provisionals. And after that, maybe buff it with a Jiffy brush, bristle brush, or any bristle brush that's able to shine things up a bit. And then from here, I place an unfilled resin glaze. I mean, you can use G-Coat, you can use Luxigate glaze, Optiglaze, Optibond glaze. There's lots of different ones you can use. The final provisionals look like that. So from here, we check her bite, make sure everything looks good, feels good, and her final provisionals look like that. All right, so it's kind of a test drive of what we want her final restorations to be. She's given oral hygiene instructions to rubber tip massage and superfloss and irrigate with hydrogen peroxide once a day as well, because I don't want bleeding gums on the insert day. So this really helps it a lot. So here's her before and after, because I said I'd take you up to provisionals today, before and after, and pre-op and post-op. And here's another pre-op and post-op retracted, pre-op and post-op retracted close-up as well. And so now you can, really catch an idea of how similar to, I mean, if you look at it, the finals are from compared to the provisionals. Katrina is a great case. So that's one case. Another case is a full mouth rehab, not prepping the teeth at all. So here goes some planning with this one as well. She comes in to see me, and she's wearing a snap-on smile or acrylic on the upper and lower arch, because deep down inside, this allows her to control the vertical dimension on it. But she was wearing this for a reason, and that is she has amelogenesis imperfecta, where she's got mottled enamel. It's discolored. You can see where it didn't develop perfectly, and a lot of bonding's been done on it. And that's her pre-op shot. And what are you going to do with this? I mean, she has stainless steel crowns put on since she was a kid, because obviously the enamel had worn away back then. So these are the occlusal shots. And, for all in all, she's got pretty good teeth. Just the enamel didn't come in perfectly. Her perio's pretty good. I mean, she's in her 20s, and, I see some wisdom teeth there. But all in all, I mean, all the teeth are there. Okay, so what do you do? So Digital Smile Design is one of the apps. You can use Smile Cloud DSD. I mean, Smilefy, a lot of different ones out there. But I like to do that to give the patient an idea what they could look like, realistically, and kind of design something. So I'd love her to look like that in the end if we could. And so this gives her an idea of what she's going to look like. And so what are we going to do here? So in our planning, we decided we're going to get all the records. We're going to do osseous crown lengthening at 4 to 13 because her teeth are a little on the short side. She's a bit gummy. A coisted programmer to verify her joint position and vertical dimension. And then we were going to do from 4 to 13 and 20 to 29 prepless Noritake felspathic veneers and Emax crowns on the first molars and Emax prepless onlays on the second molars, like tabletops. So here's the aesthetic crown lengthening. So I do a lot of that in my office because it's pretty straightforward to do. It's aesthetic crown lengthening rather than functional. So usually from line angle to line angle on the facial is what you do. And I want to reestablish a final resting place for the gum tissue about 3 millimeters apical to the CEJ. And so there's the pre-op, immediate, and 4-week post-op of the crown lengthening. And then I have her in the coisted programmer. And then with the coisted programmer to test her vertical dimension, I want to take her to a CEJ to CEJ of about 18 millimeters. So that's my desired vertical dimension. By opening her bite, it gives me room to add porcelain to the posterior teeth as well, and without prepping much of the posterior teeth, save the stainless steel crowns. So here I am, I got her holding the coisted programmer. I can do it on the intraoral scanner, digital iOS intraoral scanner as well, but this is doing it conventionally, recording vertical dimension. And I would have the coisted programmer in. I would put bite registration on both sides, take the coisted programmer out, and just maintain it. So now I've got a full, all the way around, a full bite all the way around. And these are the records for the analog prototype for her here. And the records are taken by my lab with the coist glasses. You can do it digitally as well to create a non-plaster mounting. That Panda makes these magnetic plates so that he can mount the case and do the records digitally as well. So he's got those in the lab and to design. So from there, he uses a headshot to align the digital scan to the patient's image. And it's critical that the patient's head is level or they won't align. So from here, he does an additive digital wax up on her on the upper, digital wax up on the lower, and the wax up digitally is done like this. And so this is what we would like her to look like. And so that's it from an occlusal view. And this is tried into her mouth to make sure everything is looking, it's not the prettiest, but certainly everything's in the right place. And then from here, you can see that's where she is when she smiles, and he sends everything back to me. So there's the prototype with the molar stops. I have molar stops because I'm prepping the anterior 20 first. And here's the case where the putty reduction guys are in. So how much do I need to prep really? It's all additive. I don't have to prep much. See, Meiogenesis Imperfecta has done the prepping for me. So my prepping of the teeth consists of taking a disc and rounding all the sharp edges. And here's the final impression of the preps. I use a heavy body, light body technique for if I'm taking an impression. Why didn't I scan this? Because scanning for the platinum foil technique, a scan is probably really accurate, but a printer can't reproduce interproximally all the nuances of the papilla and the gingiva as accurately to be able to do feldspathic veneers on. So if you do prepless feldspathic, I think the best way to do it is still, according to my lab, with a impression and cast. So here are the bite records at the new vertical dimension sent to the lab after prepping. And the provisionals are, he had waxed this up. So here I am using a putty matrix and Lux Temp. And we're doing provisionals lock on the top. And then upper temps to lower preps bite for the lab. So he is aware of how much room there is when we prep the lowers, how much room there is. So we divide the room between upper and lowers evenly. So he has an idea about that. And the final provisionals look like this. All right. So now you notice the molars aren't touching because we're going to work with those later. I think it's much easier for me to control the case this way. So we went from 11.5 millimeter central and also the CJ to CJ is now 17.5, close to the 18 that I wanted. Here we're picking the shade for Katrina and using the Polar Eye as well. Here's her post-op temps, and you can see she looks pretty much like a different person already. When the case comes back, we're cementing her upper and lower anteriors first, and then now we're going to go ahead and do the posterior preps and get records for them. All you can see, the posterior preps are simply taking off the stainless steel crowns, rounding off anything on the second molars, and we end up with a case. The inserted case looks something like that. So that's her smile. That's the teeth close up, and you can see the gingival response is really good. The fit is good. The blend is good. And the occlusals look like this, upper and lower. And before and after looks like that. So quite a change in terms of gum position and length of teeth. And here are her before and after smiles. So she's no longer got the stubby teeth that tip backwards that are gummy, and she's actually got a pretty nice smile. So here is the pre-op, the digital smile design simulation, and the post-op. And you can see that we ended up with a result that's pretty close to what we wanted there. This is a good case to learn from because their bell-shaped teeth can have no prep veneers. No, unless you do direct composite restorations, you can't put prepless veneers over bell-shaped teeth. I mean, here's a case I did of composite bonding and to close gaps because of age, but there's no way I could have slipped a veneer over something that's wider at the incisal than the cervical. So here's a pre-op smile of a patient, and her patient's desires are no black triangles, better shape, and a whiter color. And look at what we end up with. No reduction approach is not there, but I still wanted to be conservative. So the patient had orthodontics and connective tissue grafts. And, the preps I did fit inside the reduction guide. They're minimally prepped, but I don't think I tapered it enough because the images I sent to Nelson Rigo for approval. And it all started as a friendly call. And more or less, he says, you got to reduce it or taper it a bit more. And so here are the pre-ops and preps of me doing it the first time, but the restorations tried in, you can see, I mean, I can't get that to fit or seal at the cervical. I'm left with open margins, or I can try and seal that with composite, which I don't like to do that because it's much more difficult to maintain gingival health all the time. So I always like to say, who's the stooge? And it was me. I was just being stubborn and trying to be overly conservative. So here's after re-prepping to add a bit more taper to it, and before and after re-prepping, and you can see that there's a lot more room there to be able to fit something in. So there's the pre-op, the first set try-in, and the second set seated, and you can see that there's a big difference in terms of the final result as well. I mean, it turned out to be a great result for what we started with. So her black triangles were all closed, and it turned out really well. She wants her lowers done now, so we're in the process of getting the lowers done to close the black triangles as well. Long connectors, but for a person who's in her late 50s, that's a good result. So there you go. This is my last case, and I think I can pull it off in a minute. So this is Sarah. This is her anterior teeth, and when you look at her, she's 45, she's in good health, she's cooperative and fairly detailed, and in particular, she doesn't like her central incisor shape and overall smile. The crown on 8 matches, but is slightly rotated, and she wants an edge smile. She wants the result to look natural, so what most patients sees is this. They'll come to your office and they say, well, I don't like my smile. And it's our job to say, okay, well, what is a nice smile? What would be a smile that we would want to see? So, using a digital smile design apps are great. I agree, but I think honestly, why does it look better? Once again, the word why. We know what to do in the app and how to create the simulation, but why does it look better? And I think it goes back to what we studied in dental school is analog. This is NYU's dental smile evaluation form, which I find to be a great form. I mean, we knew all these different things. So, when you look at that, do digital tools replace analog knowledge? I don't think so. I think it's a nice adjunct to learn the principles of smile design. But in the end, I think it's a great communication tool with patients. But you as clinicians really need to understand what makes a smile look good and what you look for, because analog teaches you to see this sort of thing, like like everything, see it like that. And if you learn how to see that, then you'll understand why teeth don't look good or a smile doesn't look good when you have all these things in the picture, and how to look at each patient. So I kind of look at patients like grids as well, and be able to put them in the right place. So what are your initial thoughts here? Certainly, how many teeth would you treat? She went and had estimates and suggestions, treatment plan suggestions from 2 other consults: whiten the lower teeth, crowns on 8 and 9, veneers from 4 to 7 and 10 to 13 to correct the buccal corridor, and Invisalign for the lower arch, or maybe even 8 to 10 veneers to correct the crowding. Now, that's a lot of work for someone. My final treatment plan was Invisalign to align the teeth, in-office whitening, gingival recontouring, number 8, Empress Aesthetic crown, number 9, a wrap veneer. So here she is, Sarah, with the crowded bell-shaped veneers, bell-shaped teeth. And number 8 is the existing crown. So this is her treatment plan, all right? So we're going to take that, and the ClinCheck kind of said that, okay, well, maybe we can put these teeth here. It's going to look a little bit better. And so she was willing to do that because you're able to correct, if you look, oh, sorry, if I go back one. If you can look here, I mean, we're able to correct her, and her upper Invisalign treatment looked like that. We were able to bring her from there to there and align her, and her lower teeth, the Invisalign treatment looked kind of like this. We were able to correct her crowding there as well. So pre-op, she looked like this. Post Invisalign, what do I have? I have straight teeth, but 2 ugly centrals. So we're going to do something about that. So she did some in-office whitening, and from there we bleached them a little bit whiter. So she got a color change. And then now I send the case just to do a wax prototype for 2 teeth to my lab. And so I scan that in and send it to the lab, asking her less bell-shaped centrals, make her look good. This is my prep for 8 because that was an existing crown, and I had to reduce the dumbbells. So number 9 was a wrap veneer, minimally prepped. And her final result, 8 and 9 with Empress Aesthetics, looks something like that. And, putting it together along with the Invisalign gave her, gosh, at one time, I think there were 18 restorations suggested. We just did 2. And we were able to correct her function and everything else as well. And you can see how beautiful the restorations that Nelson Rigo did for me on her case. So she started off like this, Invisalign conservative treatment, and she ended up like that. So I'm very happy. She was very happy with the results and the great results. So it changed the way she looked quite a bit. All right, and to wrap it up, I did okay for blowing through almost 300 slides in an hour. Some of the choices we make in life determine who we are. I say that because some of the choices you make for your patients in part impacts the future of their oral health. And whether you choose different materials, you set up the way they look in the end. I mean, a big decision on your part. So closing thoughts are minimally invasive dentistry has new technical and educational requirements. And I think the golden age of dentistry is now called the digital age of dentistry because we're using so many more tools that are digitally related, whether it's scanners, mills, and 3D printers. Clinicians must stay abreast of material selection, adhesive protocol, and scientific advances because I think things change constantly. You can't stay in one place at one time as a dentist these days. So thank you very much for listening. I'll leave my contact information up there for a bit, and should you wish to contact me, and I think we'll open it up, Corin, and we can answer some questions. So I will leave that up for a second, and then I'll go to the picture view.
Perfect. Thank you, Dr. Lowe, for a great presentation.
I'm out of breath. I went so fast.
We'll give you a second to catch your breath. We do have some questions that came in already. As a reminder to everyone, if you want to receive CE credit for tonight's webinar, It is required that you complete the survey, so please click the CE Available widget for more information. We will also be including the CE link in our post-webinar email, which you will receive within a week. All right, now getting to the questions. Our first question asks, what veneer cement do you use?
There's a lot of good cements out there. It depends on what you like for viscosity. Like some people like a thicker cement. Some people like one that's a little bit more runny. My cement of choice, I think veneers, you should always use a light cured only cement. Don't use a dual cure because when you're placing, you can't make adjustments easily when something's starting to set up on you. So I use Verilink veneer, very light cure, at the LC version of that, because I think I like the viscosity. I like the fact that if it's not very viscous. It's less viscous because if I'm using a feldspathic veneer and I push down, the cement isn't so viscous that I risk snapping the veneer or something like that. Okay, so that's my cement of choice.
Okay, and do you do PVS or scanners for anterior veneer cases?
For anterior veneer cases, I mean, I'm a little bit particular, so I use scanners for anterior veneer cases if there's a margin and I can see the margin. I always pack a cord, a 000 cord, because I want the lab to be able to see the margin. If it's a prepless veneer case, though, I don't scan it. So I scan for normal veneer cases. I'll scan and take a single impression just in case. You don't have to. It's just me. I always pack a cord. But for a prepless veneer case, you can only take an impression only because if the scanner can't pick up no margin as easily for feldspathic. But if you want to do an Emax prepless veneer, you can probably get away with the scanner only.
All right, thank you. Our next question asks, how do you select shade for two centrals with number 8 is darker due to root canal treatment?
Oh, that's a great question. The darker tooth, I internally bleach if it's root canal treated. I try to hollow out the tooth, remove the coronal portion. I'll seal it with glass ionomer cement at the CEJ way down there. So that you don't risk getting peroxide down into the root, which has been known to cause external resorption. And then I'll use something like I'll internally bleach it. What you can choose to do a walking bleach. I use a product that's is a carbamide peroxide, and I'll put it on. I'll inject it into the space and seal it with a cotton pellet. And then I would replace that every couple of days until I got the prep to the color I want. Now, here's a tip for you. I mean, when you put the cotton pellet and the bleach in, you can. A lot of people use Cavit or try to seal it that way. I like to use what's that called? Lining cement on top. By 3M, because if you use lining cement, it sticks enough that it seals it, but it doesn't stick so much that you can't remove it very easily. So any glass ionomer lining cement as to seal the access opening when you're bleaching. If the tooth is really dark, you may have to prep a little bit further. Is one choice. The lab may be able to make you a coping on top of the crown if it's a crown. If it's a veneer, you may prep a little bit more. You may have to sub-opaque or mask out the color. So there's a few techniques you can work with for dark teeth. Great question.
All right. And I think this is a related question. How long after bleaching do you prepare the tooth?
Oh, external bleaching, I'm assuming, because internal bleaching, you can prep the tooth right away. External bleaching, if I whiten a person's teeth, I'd like to leave them at least for a week because I want the color to tone down. So I got them 3 shades lighter. it will tone back down to maybe 2 shades lighter often because some of it is dehydration. So I don't think that prepping bleached teeth matters. I think it's more for shade selection later. Let's say I'm doing 2 centrals. I bleached everything. Well, I can prep the centrals that I'm going, the ones I'm going to prep. It doesn't matter. I'm stripping the enamel off for the most part, but the teeth beside them, when you go to pick the color, you want to let them rest for a week so that you don't end up with centrals that are too light.
All right, thank you. A few more questions coming in. Any problems with bonding veneers over an opaquar that was placed to mask the discoloration?
No problems with bonding veneers over an opaquar. I just don't, I try to use opaquar. I don't like using opaquar, first of all, because I think opaquar is kind of reserved to cover metal and everything else. I think opaquar sometimes makes the tooth look dead. If you can imagine, teeth are like 2%, a glass of 2% milk, or a glass of skim milk. So opaquar is like cream. So you put some of that over, and now you're trying to hide that opaqueness. The hue or the color might be correct, but it often it's a little higher in value, and it looks a little bit more opacious, right? So if I were to, it's not that there's a problem with bonding. I think crowns are more successful, but when you actually place the opaquar over it, I use it very sparingly. I don't like to paint the whole thing with opaquar unless the crown's super thick. Like if it's an Emax, it's going to mask the opaquar. But no problem with things debonding. Just be careful how much of it you use. I'd rather use a composite that's opaque to to bond to the prep, to be able to put my veneer over, than opaquar itself, which tends to be something like Dycal in consistency.
Sure, thank you. Our next question, how does the Kois, I might have pronounced that wrong, deprogrammer work?
It's a great tool. You can look up Kois deprogrammer and what it is. A Kois deprogrammer, when you're opening the bite, a Kois deprogrammer is an appliance. It's much like a Hawley appliance with an anterior discluding element that fits behind your upper centrals, and your lower 2 lower centrals just touch, and it's slightly open to give clearance to the posterior teeth. And the idea is that if you have a constricted chewing pattern or a constricted bite, what if your jaw moves forward? Because I've had cases of veneers where I prepped the case and the bite was where it should be, and then when they have their temps on, they come back a week later and they say, I'm only biting on my posterior second molars. Well, why is that? Maybe their joint has moved to a new position. Maybe their jaws come forward a bit. So a deprogrammer, what it does is it allows the jaw to move freely, like it's like 2 hockey pucks rubbing together. And the jaw can find the position it's comfortable in. And I usually have the patient wear it for a week. And when they're comfortable, they come in, I have them sit straight up, I have them tap up and down. I want a repeatable position. So if the position's different, then I record that, and if I'm building a case, I build the case around that, because I now have a jaw joint that's in a more orthopedically stable position from wearing the deprogrammer, and now I can build around that and not make a mistake. It's a big mistake if you restore 20 teeth or more and the teeth don't fit together. So it's better to take that extra step, in my opinion.
Thank you. All right, last question for tonight. Can we repair chipped veneers with composite, or does it have to be replaced?
Well, a chipped veneer, depends on whether it's catastrophic or not. Like if you chipped a little bit off, I think it's a thing I do a lot. You can repair it with a composite. Usually, you treat it like a tooth. You're going to have to mask it out. My recommendation is you cut a bevel, take the sharp edges off. You etch it for maybe 20 seconds with hydrofluoric acid. Paint a little silane on it on the porcelain portion. Put a little bonding agent on it, and then treat it like tooth and restore it and polish it. be careful, certainly if you're going to use silane, don't get it on the tooth because it doesn't like to stick to that. But you can certainly repair it. But catastrophic, if half the veneer's missing, I mean, it's probably time to replace it. But if it's, you chip the corner off and it's not that large, you more than likely can repair it with composite.
Great. Well, that wraps up our Q&A session. Thank you, Dr. Lowe. I appreciate it.
You're welcome. Thanks for having me tonight, everyone. And I wish I had more time to speak. I condensed a pretty much an all-day lecture into as much as I could in an hour. So I hope you enjoyed that.
Yeah, I definitely think it was super valuable. So thank you, Dr. Lowe, and thank you so much for everyone for the interest in tonight's webinar topic and for your questions. As a reminder, we will be sending out the recording in the next week via email, which will have the CE link if you're interested. So thank you again for joining, and thank you for your time, Dr. Lowe. Have a great night.
Well, thank you, Corinne. Thank you, everyone. Good night.